Senator, thank you so much. We're now going to be going to Carol Schroeder, Executive Director of the Alliance for Child and Family Services. Mr. Schroeder is also going to be talking about some of the gaps that he also sees within the current system. And again, we're really grateful that you're here.
Thank you, Mr. Chair. Senator Hernandez, some foster youth with mental health challenges need psychotropic medication. Some need psychosocial interventions, and some need both. Problems occur when the only therapy caregivers can readily access is psychopharmacological. Psychotropic medication is the one mental health therapy foster children and youth can access consistently throughout the state. Yet the list of mental health psychosocial interventions ostensibly available under EPSDT to children in foster care is long and quite varied, from individual therapy through collateral contacts to therapeutic behavioral services and intensive home-based services and so on. And all of these can be provided by county mental health plans and private organizational providers. Some of them can be provided by managed care organizations and individual therapists or psychiatrists. And with such an exhaustive list of services and providers, it would seem that psychosocial mental health interventions should be readily accessible and available. But if you're a caregiver and you're caring for one of the 80% of children in foster care that some researchers have estimated require mental health treatment, where do you go for help? How do you access those psychosocial interventions? I raise this question because although the bills addressing the use of psychotropic medication with foster children focus on youth in group homes, it's important to remember that the vast majority of young people in group homes are placed there after multiple unsuccessful placements with kin and with foster families. The Emily Q and KDA lawsuits demonstrated that many of those children first entered foster care and later ended up in group care because their mental health needs were not being met. So does the caregiver go to the county mental health plan to get help if she even knows about it? And if she goes there and her child receives a screening, how long it be until the child receives an assessment? And then how long until a treatment planning meeting is convened? And then how long until the child receives the needed psychosocial interventions? Or does she go to the child's physician, a trusted professional she knows to ask for help? And psychotropic medication can be prescribed by any licensed physician. So how quickly can she receive help from the physician in the form of psychotropic medication? And what caseworker or court is going to deny a prescription when the caregiver is at her wit's end and is demanding help now? If we really want to reduce psychotropic medication usage in group homes, we must ensure that children in all kinds of foster care placements, regardless of county, have timely access to high-quality psychosocial services that are culturally appropriate and effectively meet the child's needs. Department of Health Care Services has got to complete its performance outcomes system it's developing for 4 years so it can monitor and enforce the county mental health plan compliance with the EPSDT entitlement. The Department of Finance must use realignment growth allocations to incentivize low-performing counties to increase the provision of those psychosocial interventions. Counties must monitor contract providers for demonstrations of positive outcomes. And the collaborative CWS, Child Welfare Services, mental health joint management structures that are part of the KDA settlement agreement must be established and utilized in every county to ensure that all children in foster care receive the mental health services they need and to which they're entitled.
We appreciate that, Mr. Schroeder. I want to see if there's any questions from Senator. Thank you. I just had one question. You had just mentioned there at the end I'll call them the points for success in which is needed. If you want to talk about what, in your point of view, with all of your experience, biggest hurdles towards implementation has been what?
In terms of measuring successful outcomes? Well, I think there needs to be agreement across the board on what constitutes successful outcomes and how to measure it. And I think Mr. Gardner's approach in using the cans is one that we have also advocated for many years. Like, let's find an instrument that we think measures functional performance, improvement in performance, and let's settle on that across counties, and let's use that as a measure for kids and for their providers.
Voluntary versus mandatory. What's your stance?
Well, I think it's got to be mandatory that we measure it. I don't think that there's any way we can get around that. I don't think we can make it voluntary. Is it? I don't see how you do.
I mean, I think I'm going to give you my own editorial. I think that's the frustration that we currently have right now. For example, if we're talking about the guidelines of what we want to be able to see from counties, yet if they're not mandatory, it's ultimately up to the board of supervisors or the public health professional, whether it's the Human Services Director or with the Human Services Department, to be able to implement. And if they do, even better. If they don't, there simply aren't any consequences. I think that's the challenge that we're starting to see. Please.
it seems to me that we get into this conversation a lot, and it seems to me that one has to ask the question, why would people be so opposed to mandatory measurement, even though they know that by measuring we can improve quality? And I think by understanding the motivation behind the concern, one can begin to address the problem. And one of the key motivations behind the concern is that people don't want to be responsible for things they can't control. And one of the aspects of children's mental health in the foster care system is you have two systems that are responsible for these children, and typically they are not accountable to one another, and they don't necessarily trust one another. And so the fact is that the social workers often think that the services that the mental health providers aren't helping them. And the fact is that the mental health providers often think that the social workers couldn't give a hang about what they say and don't even care enough to call them up when the child moves and has to have a new therapist. And so when you have that challenge, it's very difficult to walk in and say, okay, now you're all going to be measured. Now we're gonna essentially give you a grade, and you're not going to have any technique or method from which to fix the problem. So one of the things that we have to pay close attention to is, if we're going to measure, we have to give people the capacity to do better. So there has to be a feedback loop. There has to be a technique for using the information effectively to actually improve care. When we give people those tools, they tend to pick them up and use them. That's one reason why people think voluntary is good, because if we're providing value to a provider or to a clinician, they'll use the tool we're providing them. Right. If they think they're just going to get slapped down because they can't measure up, then they're going to refuse to use it. Right. So I think that this notion of voluntary and mandatory is a little bit not really the point. It's what's valuable to clinicians to improve performance. Let's focus on that. Let's provide that. People will use it.
I appreciate that. And before we go to Mr. Castrillo, Mr. Schroeder, I wanted to see, I didn't mean to interrupt, if you had another item you wanted to close with, or any other last thoughts.
No, that's it. I wanted to agree with Mr. Gardner's observations.
Okay, thank you so much. I'm really grateful that you're here. Thank you so much. We're going to be talking with Mr. Castrillo now. He's a legislative advocate for the California Academy of Child and Adolescent Psychiatry. He's going to be bringing us the perspective on challenges to be able to provide appropriate care and from a medical professional perspective, as well as prevent over-medication. We're really glad that you're here again today. Thank you so much.
Appreciate that. Happy to be here. Mr. Chair, Chair Hernandez, Chair McGuire, both your consultants, thank you for the opportunity to speak here today at this informational hearing. As Chair McGuire mentioned, I'm Christopher Castrillo, legislative advocate for the California Academy of Child Adolescent Psychiatry. Our organization has been closely involved with the issues of misuse and inappropriate prescribing of psychotropic medication in the foster care system throughout the year. We applaud you, your fellow senators, your counterparts in the Assembly, the advocates, for your leadership on these issues. Our organization agrees that policy solutions to help reduce the dependence on psychotropic medication and to increase the quality of care, which has been mentioned before, and services provided to kids in the foster care system are long overdue. Our priority is to ensure, first and foremost, that children and youth are protected. That's the mission and the reason why CaliCap was formed in the first place. Second, that protections are put in place to ensure that as medically trained doctors in the field of psychiatry, the medications that are prescribed are readily available when patients need them, with proper safeguards and oversight measures in place for preventing overuse and inappropriate prescribing. We want to improve outcomes for all kids in this process and want to ensure that children aren't harmed by delays in timely access to appropriate prescriptions that will aid in their care, while working to ensure that medication is provided when medically necessary and as part of an overall behavioral health plan. For our organization, one of the most significant hurdles in providing well-informed, high-quality care to foster youth is that a huge information void still exists in knowing the full medical history of children and youth in foster care. When young patients in the system are referred to psychiatrists, all too often doctors have not been provided information on family histories, past hospitalizations, medication history, general health care history, reasons for placements, etc. Improving the system of healthcare information history transfer, expanding the use of electronic health records, and working on ways to designate a single point of contact for this information history will help improve the quality of care for foster youth and reduce the potential for inappropriate diagnosis, polypharmacy, and incorrect dosages. While electronic health records are becoming more commonplace, doctors still do not have access to all the information when they need it to more safely and more effectively prescribe medication. Additionally, as we've talked about, medication should only be used as part of an overall behavioral health plan. Unfortunately, it's no guarantee that a child has access to and is receiving evidence-based, non-pharmacological treatments either in concert with or in lieu of medication management. All too often, there has been no front-end care by the time they see a psychiatrist or another prescribing physician. Today's informational hearing so far has done a great job in taking a closer look at this issue, and we appreciate the work of both the committees of consultants here to find solutions that will help ensure that foster youth are provided the access to and are receiving the care they need and deserve. We think it would be worthwhile to examine ways that a child and adolescent psychiatrist can be involved earlier in a foster youth's mental health care treatment, which would include a broader discussion around staffing within the foster care system. Child and adolescent psychiatrists have broad training in multiple areas of development and developmental psychopathology, and their biosocial knowledge can be used more effectively as an integral part of the ongoing assessment and treatment process. We believe there is great potential in utilizing child and adolescent psychiatrists to better train, educate, and prepare other prescribing physicians and other healthcare professionals involved with foster youth to provide high-quality mental health care treatment and medication management throughout the system of care. Our organization also recognizes the need for an informed and effective medication authorization process for children in foster care. As we look forward to ways to improving oversight and to ensure that foster children are receiving appropriate care, we also want to ensure that the safeguards being considered are more than just barriers to treatment, but truly help improve the quality of care provided to a child. Additionally, the expansion of the treatment authorization request requirement is less than a year old, and will continue to collaborate with the Department of Healthcare Services to ensure this review process effectively oversees psychotropic medication management for foster youth and does so in a timely manner that ensures medically beneficial treatments for youth are not delayed. The Global Data Sharing Agreement shows promise for important data and metrics that will allow for a better understanding of the care being provided to foster youth and who's providing that care. We find that a robust peer review process to better examine and educate other prescribing physicians can be a helpful tool to ensuring better oversight and monitoring is in place.
30 seconds.
Appreciate that. About to wrap up so timely. We'd like to thank you and the stakeholders represented here for your continuing work on this important issue. Our organization is committed to continuing to work with the legislature, the departments, and advocates on improving the quality of care for all the foster youth in our state.
Mr. Castrillo, thank you so much.
Yeah.
Any questions, Mr. Senator? No, thank you. Very grateful. And I have a question. We'll let the remainder of the panel go forward, and then we'll come back.
Appreciate
so
that.
much. Would now like to be able to introduce Gail Johnson-Bond. She's the Executive Director of Families Now. Ms. Johnson-Bond is going to describe the core elements of effective mental health services for foster youth, and we're really grateful that you're here today. Thank you so much. It's good to see you.
Thank you so much, Senator and Senator Hernandez. Families Now advocates for children in foster care from the perspective of permanence, and my comments bear that particular impression that's so important. I've provided you with written testimony. I'm only going to do oral testimony for part of it, but I hope that you'll take the time to read the 3 pages, because there are things that I think will help you in your thinking about all of this. I want to start out quickly talking about why there is such a high incidence of mental illness in children in foster care. And I would point out that our Department of Social Services and counties have done a tremendous job in reducing the number of children in care. Since 1998, our number of kids in care has been reduced by 46%. The children who remain tend to be the ones who had the more difficult situation. They are more traumatized. They come in with mental illness, whatever. So it makes sense that a higher proportion of them are going to have mental health illness. In spite of the fact that 46% reduction over that same period, the number of children emancipating without families remain constant at about 4,000 kids every single year. Once those children are in care and do not reunify, then the likelihood of them being able to stay is them being able to achieve families is very, very low. In fact, unresolved issues of trauma, loss, and grief are the primary reasons behind placement instability and lack of achieving permanence. I'd like to talk to you, and I would also say that when those children do actually achieve permanence, which we have some amazing programs that are showing that that is possible, they bring with them those mental health issues. And so I can't say too strongly that we need to look at the mental health needs of our adoptive and guardianship families as well, not just. So I want to speak briefly about why appropriate services in many cases are more effective than psychotropic medications. So what we need to remember is that, as you well know and spoke originally, that psychotropic medication may well mask the symptoms that need to be dealt with. And these symptoms follow the children when they are not healed into adulthood, impacting their own children and driving the intergenerational nature of foster care and trauma-related mental illness. So no, I thought perhaps someone else might speak of the brain science behind this, and I want to very quickly do that. What we need to know is that our brains, even as infants, have the capacity of making generalizations, of forming mental models from repeated experience. And this happens with our children as well. Those mental models actually influence the way we perceive reality and actually change the reality that we see as opposed to what someone else might see. And it impacts the way in which we then face future experiences. So if you have a child that has had an experience of their primary caregiver or someone else that they should have been protected from by their primary caregiver, hurting them, challenging their very survival, when they are going to carry that, not necessarily as an active memory, but as an implicit memory, which means that it happens below their whole consciousness. So you have a child who goes into bringing that mental model into a foster placement, and their mental model is that parents aren't safe. And so the parents behave in a way that may not say to someone else that they're not safe, but to this child, for instance, they pull the curtains down at bedtime or other things that trigger that implicit memory. Then the child will protect themselves in a way that is off-putting to the parent. They may withdraw and not give the feedback and warmth and engagement that the foster parent needs. They may act out in behaviors which are simply unacceptable, breaking walls, hurting animals, all the rest, and that in itself results in the move. We see this happening all the time. You need to understand that that behavior isn't consciously chosen. The child's behavior is not saying, I won't behave. It's saying, I can't behave. My brain is being hijacked by my past trauma. I have stress chemicals washing over my brain. I can't tell you directly, but I'm terrified. I've attached a page of behaviors that are connected to this on the back. I can get you bigger ones if you want, but you can see how these behaviors translate, and the fear, flight, freeze, all of that stuff. Very, very interesting stuff. So if we are not addressing the needs of these children, if we're not decoding these behaviors by saying what's actually going on with this child, what are the needs that they have, how can we help them, and instead and help them inside a relational area where they can reprogram their brains that relationships are safe, we're going to see this.
We have about 30 seconds.
Okay, so I'm going to jump right down to the very end around the solutions. I believe that there are three primary areas that we need to look at here. One is the integration of child welfare and behavioral health services, which we've spoke about here, and Patrick is absolutely right about that. The second is provision of behavioral health services within the context of family. These complex, by nature, severe issues are best served by therapists who possess a diverse repertoire of clinical knowledge and skills embedded in attachment theory, family systems theory. You can't heal those things without a family, and others as well. And then finally, our children's specialty mental health services are structured in a way that actually prevents them from meeting the needs of our children. And I've gone into some detail on that in the written testimony.
No, thank you so much. We're really grateful you're here. I'm going to have a follow-up question as soon as we're done with the panel, so thank you so much. And we're really grateful.